Yes, I think the striking observation has been a steady reduction in transplant-related mortality in patients going to an allogeneic transplant, and that's because of reduced infectious risk, because of better supportive care, but also I think, particularly in the last 15 years, improvements in graft versus host disease prophylaxis. So we've got much better at reducing transplant-related mortality, although it remains substantial, about 20%, 15 to 20% at 2 years. What we really haven't failed to tackle is a stubborn, persistently high rate of disease relapse post-transplant. And there's really been very little reduction in the risk of disease relapse in patients allografted for AML, which can range between 30 and 60%. And it's for that reason that prospective trials, such as those delivered by the US BMT-CTN or the UK Impact Group, are so important. And strategies we can adopt are to think about trying to minimize pre-transplant MRD by particular interventions, or trying to improve a conditioning regimen such that the anti-leukemic effect is maximized with no increased risk of toxicity. And then finally, I think the most promising avenue is how do you maximize the graft versus leukemia effect post-transplant. And I think that's increasingly where the field's moving. Can we think in high-risk patients about early post-transplant MRD monitoring? Can we think about withdrawal of immunosuppression in those high-risk patients? The results of the PRO-DLI study delivered by the UK group looking at the benefit of prophylactic donor lymphocyte infusion will be available next year. And then finally, of course, the Morpho trial demonstrates that in patients who are pre-transplant MRD positive and allografted for FLT3 positive AML, there is clear survival benefit, clear event-free survival benefit of maintenance with gilteritinib.